special classes.
With this, I welcome Professor Talvir Sidhu. She is at GMC Ludhiana, an ex-alumni of RPC. She is a prominent glaucoma specialist and she'll be talking to us about the conundrum of glaucoma in myopia.
Good morning to everybody. So the conundrum of glaucoma in myopia is because this is not progressing. Please see. Yeah. So as we all know that nowadays the pandemic of myopia has already started, and in addition to that, myopia has been an established risk factor for glaucoma. And with the increasing age, as myopes are also increasing in the also aging, there is a 6-fold higher risk of glaucoma in myopes. It has been shown in various studies that high myopia, it leads to early development of glaucoma, though there is not much evidence that it leads to early progression of glaucoma. So why does myopia lead to development of glaucoma? Is because of the mechanical effects on the lamina cribrosa. So there is stretching and thinning of the lamina cribrosa, as well as there are myopic deformations of the optic nerve head because of tilt and torsion, and because of the mechanical deformation of the optic nerve head, also the vascular supply of the optic nerve head gets disturbed, which can lead to mechanical pressure over the ganglion cell, the RGCs, which can lead to glaucoma formation early. So glaucoma in myopia is very difficult to diagnose clinically. Why? Because of the large peripapillary atrophy that can be present along with glaucoma in myopia. It is difficult to first ascertain what are the boundaries of the optic nerve head. So here we can see that there are thin black arrows forming the boundary of the optic nerve head, and this figure A actually shows a glaucomatous optic nerve head, where we can see that there is a bending of vessels right at the edge of the optic nerve. But similarly, in the lower picture, there is a large peripapillary atrophy and optic nerve is lost somewhere within. So the black arrows are actually marking the optic nerve head margins, and because of the stretching of the optic nerve head, it is difficult to ascertain where is the cup and where is the neuroretinal rim. And we can see that the vessels are bending right about here at the thick arrows. So that is how we can ascertain sometimes that what is the cup margin. Also in these discs, sometimes the circle of Zinn-Haller actually comes outside of the optic nerve margins, which can lead to a compromised blood supply, and there is a large gamma zone of peripapillary atrophy. Fallacies, when we talk about the clinical diagnosis, if we are not able to diagnose, we rely on the visual fields, and if not visual fields, we rely on our OCT. And we all know that most of the glaucomas in India and in our country, they have lower IOPs than 20 millimeter of mercury, because usually the higher IOPs will be shown in DVTs when you're doing it early mornings, and patients to us are mostly presenting in the afternoons or evenings when the IOP has actually come down. So while we are testing visual fields in in myopia, we see that there are 10 to 17% of high myopia without pathological changes of glaucoma. They have visual field defects, and what contributes to those visual field defects is, first of all, lens rim artifacts. So in any person who has a more than 4 diopter myopia, it is important to use contact lenses while doing the visual fields. All right, and after that, it has also been shown that the myopia itself, when there is an increase in myopia by 1 diopter, the mean deviation can actually decrease by 0.2 decibels in these eyes. So that also should be taken into effect. Along with that, if there are optic nerve heads which are tilted, they can have congenital defects in the visual field and RNFL, which can be present along with the tilt of the optic nerve head. Those also have to be kept in mind. If there is no family history of glaucoma and other risk factors of glaucoma are not there, so that the visual field defects, such visual field defects should be monitored for progression. Another important thing that happens in very high myopia is the papillomacular bundle defects that can be present in myopes in early glaucoma. So these should be ruled out with the help of a 10-2. It can be missed on a 24-2 because there is a 6-degree difference between each point on the visual fields that we do. Now coming to OCT. So once if our visual fields and optic nerves are looking like, very non-decisive about having glaucoma or just high myopic findings, then we tend to rely on the OCT in myopia. But OCT itself also has some fallacies. Don't worry, I'll come to a part where I'll provide some solution to all these problems. So when we do OCT nowadays, the neuroretinal rim width is actually taken into consideration most of the time, and the neuroretinal rim is actually taken from the Brooks membrane opening to the rim. So here we can see this is the Brooks membrane opening, but the rim on the optic disc margin is actually here. So because of the peripapillary and the gamma atrophy, not just beta atrophy is present, gamma atrophy is where actually your Brooks membrane is pulled away from the optic disc margin. So here you can see that the Brooks membrane opening has actually shifted away. So this was a child who was followed up for 6 years, and it showed that actually the Brooks membrane opening has shifted away from the optic disc margin, which will not give you very good neuroretinal rim findings. So this is another thing that we have to take into consideration. Segmentation defects can also happen on OCT. So here we can see this is a girl who came to me, was diagnosed with glaucoma. She had a very large optic nerve head, -16 myopia, and once we did a retinal nerve fiber layer thickness map, we saw that the circle that is actually 3.54 millimeter in diameter, it was passing through the peripapillary atrophy area, which was showing a falsely low RNFL. So that this is what can happen in highly myopic eyes, that the peripapillary retinal nerve fiber layer we cannot calculate because there is definitely it passes through the peripapillary atrophy areas. So later on, what most of the doctors have done is they are looking at the deviation maps which can be seen in glaucoma. But there is some fallacy about the deviation maps in glaucoma, in myopes also. There is always a temporalization or temporal shifting of the retinal nerve fiber layer that happens in high myopes. So in a normal person, as you can see here, that the retinal nerve fiber layer is actually going along very well with the arcade, but here also you can see that the arcade itself has shifted temporally, and this is the result of this. So what happens is, we can see here that there is a temporal shift in the retinal thickness map that is happening, which is giving us a falsely low RNFL in the infratemporal quadrant in both the areas, which is giving us the inferior neuroretinal rim or the inferior RNFL as a thin RNFL compared from the normative database, which includes non-glaucomatous eyes. So what happens here is there is a very high temporal neuroretinal rim and a low inferior rim. So it is important that once you are diagnosing a glaucoma person with myopia or doing OCT, you should look exactly at these maps, that if there is temporalization of the retinal nerve fiber layer, do not think that otherwise the retinal nerve fiber layer has been thinned. So nowadays what is happening is, we are all looking at NFAS images. So here also we can see this is actually the NFAS image, and it is giving us some thickness of the retina. We know that the retinal nerve fiber layer, although shifted temporally, here also although it has shifted temporally, but we can see a very good thickness map on the NFAS image. Similarly, if you look at this eye, here you can see a wedge-shaped RNFL defect, which is actually corroborating with the visual field defect, although some peripapillary atrophy is present. So NFAS imaging has been shown to give a very good picture. Also, people have combined the wide field OCT angiography along with the retinal thickness maps. So here you can see that there is a RNFL defect which is actually the optic disc ahead, and you can see there is retinal thinning which is corroborating with the visual field defect. So this is important to note, that you can use various imaging modalities on the OCT. It is important to note that the ganglion cell thickness actually has a very good sensitivity and specificity for picking up glaucoma in high myopia. What happens in, can I please take just 2 minutes because I'm going to finish this?
Yeah, carry on.
So in ganglion cell layer thickness, you will see that the ganglion cell thickness is actually thickest along the superior inferior part of the a part of the macula. Here what happens is, if you actually look at the ganglion cell thickness in glaucoma, you will be able to see that it corroborates with the horizontal thinning of the retinal nerve fiber layer. Here you can see a wedge defect which is actually going up to the horizontal raphe on the temporal side of the macula, which is giving rise to this visual field defect. Similarly, in myopia also the same thing can be done. It is called a GCIPL hemifield test. So this is a very significant thing that can be seen in the eyes. It is important that you do a intra-eye comparison. Intra-eye comparison means that you compare the superior GC the ganglion cell layer with the inferior hemifield ganglion cell layer. The accuracy is actually very high, 92% and 95% specificity. So another thing is glaucoma loss volume, which is the ganglion cell loss volume, which can also be seen in myopia. So the conclusion is, a solution to this problem is that when you look at a person who has come for glaucoma, also has high myopia, please look at everything. If there is a high IOP or there is a normal IOP with low corneal hysteresis, if there is neuroretinal rim thinning, even if this is not diagnosed, there is a visual field defect and there is a GCC hemifield test also is defective, then you can definitely term a myope with a glaucoma and you can treat. So this is the conclusion. Thank you so much. Another important thing is, don't ever think that you do not need to do gonioscopy in a myopia person. They might have angle closure. Always do gonioscopy in every person you suspect of glaucoma. Thank you.